Okay, cool. Well, let's go ahead and we'll go ahead and get started. Finish up. I did want to make a quick note. When I talked about special senses, I didn't really go into this, and you're not really going to have to know in any detail. But how do we measure the sound, the amount of pressure, the amount of intensity that a sound puts on our ear? Specifically, the potential for that type of noise to damage our ear. What is the unit by which we measure that in? What's that? The decibel, yeah. The decibel. You're not going to have to know the decibel scale in significant detail. It is a logarithmic scale, so it has an exponential kind of feature to it, where it gets orders of magnitude more powerful. Okay, so 70 decibels versus 60 decibels, 70 decibels is going to be significantly louder than 60 decibels. Just like when we talked about the pH, how that is it is orders of magnitude as well. It is somewhat of a similar concept with decibels. What you do want to kind of focus in on with decibels is where hearing loss will be a problem, okay? And generally, sounds above 90 decibels for sustained, so sustained exposure to sounds above 90 decibels can result in hearing loss. And then sounds above 140 decibels, okay, will, even short-term, okay, short-term exposure to sounds above 140 decibels will tend to cause fairly immediate hearing loss or damage. Okay, you guys okay with that? So what does that mean in real term? Well, you guys know what a jackhammer sounds like, right? If you're about 50 feet away from a jackhammer, that's about 95 decibels right there. Okay, just to kind of give you a point of reference. Whereas if you pick up like a telephone and you hear that dial tone in your ear, that's around 75 to 80 decibels. Okay, so it's a big jump from that to 95, right? Again, because it's orders of magnitude. Just the kind of a normal, quiet conversation is right around 60 decibels. A shotgun is going to be around 160 or so decibels. Okay. So anyway, those are just some values, not for you to remember, but just to kind of give you an idea of what some of these sounds would register on the decibel scale. Okay, so let's now go ahead and finish up talking about endocrinology. And this is going to be just a little more detailed in the lab. And I have an annotated drawing of that really nice drawing that I had in the lab. Sorry, you guys don't get the nice drawing today. You only get one nice drawing out of me, and the rest of it's annotated. It's okay. So first of all, let's just talk about how cells communicate before we get into the endocrine system. There are basically 4 ways that one cell can communicate something to another cell. Okay, you can have direct communication. This tends to be between 2 adjacent cells that are connected by a gap junction. Remember, we talked about that way at the beginning of the semester. We talked about gap junctions and tight junctions. And so a gap junction is a little pore in between 2 cells that allows them to send ions or secondary messenger molecules between one another. We also have what's known as paracrine or paracrine communication. And this is communication that occurs in cells that are fairly close to one another. And what happens is one cell secretes a substance or excretes a substance, if the case may be that, into the interstitial fluid, and then that substance diffuses to the other cell. Okay, does that make sense? So you have a group of cells that are fairly close by, one of them or a couple of them secrete or excrete some sort of chemical messenger, and then it kind of diffuses throughout the interstitial fluid into the cells. Okay, that's paracrine. And then we have what's known as endocrine. Okay, and this is what we'll be talking about today. And endocrine is where messenger molecules are secreted or excreted into the blood and then transported throughout the body via the blood circulation. That is endocrine. And then synaptic is the other, and I just threw that in to be for the sake of completion, and that is where you have communicating molecules, neurotransmitters, crossing the synaptic cleft or the synapse to attach to receptors. Okay? You guys okay with that? Now, there are 3 general categories of hormones, and these categories are based on their chemical structure, their chemical composition. And just as a side note, many hormones are what are known as prohormones. Have you ever heard of that term, pro? So if I say something is a prohormone or a prodrug, for example, pro means that it's inactive. Okay, so a prohormone or a prodrug, there are lots of drugs that are inactivated, and then they are turned into their active form by some chemical process, generally an enzyme, converts them into their active form. Okay? So many hormones are actually originally produced as prohormones, and then some other enzyme or some other messenger molecule interacts with that prohormone to turn it into its active form. Okay? Does that kind of make sense? And some hormones are just produced in their active form natively as well. Okay, so the 3 types are, the first type are the amino acid derivatives. Okay, so these are derived from amino acids, so as you might imagine, they're fairly simple, right? They're fairly simple, fairly small molecules. Okay, and there are basically 2 general types of amino acids that go into these, tyrosine and tryptophan. Okay, tyrosine is the amino acid where your catecholamines come from. So epinephrine, norepinephrine, dopamine. Okay, those kind of come from the tyrosine. And your thyroid hormones are also amino acid derivatives that come from tyrosine. Okay. The other type are tryptophan. They come from the amino acid tryptophan. And these include things like 5-hydroxytryptamine or serotonin, dopamine, and melatonin. Now, many of these can also be neurotransmitters, right? But what is a differentiation between a neurotransmitter and a hormone? For example, dopamine as a neurotransmitter versus dopamine as a hormone. When would we call dopamine a neurotransmitter?
When it's in the nervous system?
Okay, but the nervous system ultimately controls, right, everything. We call something a neurotransmitter when it involves synaptic communication. Okay, when it gets dumped into a synapse or a neuromuscular junction and attaches to receptors on the other side of a synapse, we would call that a neurotransmitter. But if it was, say, epinephrine that gets squirted into the blood from a gland and then circulated throughout the body, it's the same chemical, but the delivery mechanism is different, and in that case we would call it a hormone. Does that kind of make sense? Okay, so the hormones have this endocrine action to them, primarily. All right. The next one are what we call your peptides, right? So a peptide is 2 or more amino acids combined together, right? Going back to the beginning of class. So these tend to be a little more complex and a little larger than the amino acids, and we have several subcategories. We have what are called your glycoproteins. So these are proteins that have a sugar molecule, or in some case more sugar molecule, or what we call saccharides. Okay, so a sugar molecule or multiple sugar molecules attached to them. That's why we call them glycoproteins. And these include things like thyroid stimulating hormone, or TSH, luteinizing hormone, or LH, follicle stimulating hormone, or FSH. Okay. We also have what are known as short chain polypeptides. So these are not proteins. These are small chains of amino acids. These include things like antidiuretic hormone and oxytocin, okay? And then we also have what are called small proteins. So these are larger than polypeptides, but they're still fairly small, okay? And not as, and not, huge. And these include most of the hormones that come from your hypothalamus, hormones that come from your heart, hormones that come from your gastrointestinal tract, and hormones that come from the posterior pituitary gland. And as we learned in lab, the posterior pituitary gland is nothing more than an extension. It's a direct extension of the hypothalamus, okay? And then I'd also say that insulin, okay, even though I don't know that the book, I'm not sure it specifically says that in the book. I did not see it in the PowerPoint, but insulin is considered a peptide hormone, and because insulin is such an important hormone, I did put it in brackets here. And then finally, the third class of hormones are your lipid-based hormones. These are primarily hormones that come from things like cholesterol and other fatty acids. Okay, so you have what are known as your eicosanoids, and that just means a 20-carbon fatty acid. Okay, eco is 20-carbon fatty acid. The typical fatty acid is something known as arachidonic acid. And these include things like clotting factors, leukotrienes, prostaglandins. Very important when it comes to inflammation. So when you guys study the immune system in gory detail next semester, that's a tough one. The immune system can be a tough one to study. These particular substances are going to come up again because they're very important when it comes to the inflammatory process. We won't talk about them in detail today. And then we have what are known as your steroid hormones, your steroids. And these are hormones that do not come from arachidonic acid, but rather they come from cholesterol, right? We thought all cholesterol is bad. Well, it's not, right? Cholesterol is important because it helps stabilize the cell membrane, right? Give the cell membrane some strength. And we use it to make lots of different hormones, specifically our sex hormones. So things like progesterone, estrogen, testosterone. Okay, those kinds of hormones are all come from. They're all sex hormones. They all come from cholesterol, and then your steroids, your corticosteroids, are also steroid hormones. It's in the name, right? And these include things like cortisol. And cortisol includes your mineralocorticoids and your glucocorticoids, right? And these all come from the adrenal gland. And the mineralocorticoids help us regulate water and electrolyte balance. And the glucocorticoids help us regulate glucose levels. How about that? All right. Okay, cool. All right, so those are your three classes: amino acid derivatives, peptides, and lipids. So far, so good? Yes. All right, cool. So let's just review where it kind of all starts, okay? And it starts in the hypothalamus up here, right? And then and then just underneath or just inferior to the hypothalamus is the pituitary gland, and it has two general structures. It has an anterior lobe and a posterior lobe. And let's start at the posterior lobe first. And the posterior lobe, again, is a direct extension of the hypothalamus, right? The neurons that begin in the hypothalamus, their cell body begins in the hypothalamus, and their axons end in the posterior pituitary. So the posterior pituitary gland is very much a direct extension of the nervous system. It is nervous tissue. And the two major hormones that come out of the posterior are antidiuretic hormone, or ADH. Okay. An antidiuretic hormone acts on the kidneys, right? And what does it do? Well, it's antidiuretic, so it prevents us from urinating, right? Prevents diuresis. So it causes us to hold on to water. Okay? And then oxytocin is the other hormone that comes from the posterior pituitary. And oxytocin, okay, is very important when it comes to the uterus, right? Because it stimulates uterine contractions, and we want the uterus to contract after birth, right? That helps stop the bleeding, right? Helps stop the bleeding. All right, good deal. Now let's talk about the anterior. So the anterior pituitary gland is a little different in that it has its own endocrine cells, right? But those endocrine cells do not secrete hormones until they are activated or they are told to by neurons that secrete hormones from the hypothalamus. So it's a kind of a double hormone system, right? For the anterior pituitary to work, you have to have neurons in the hypothalamus release hormones onto the cells within the anterior pituitary and activate those cells or to tell those cells to secrete their hormones. Does that make sense? Whereas the posterior pituitary gland is just an extension of the hypothalamus, so you don't need that double hormone system going on there. Okay? Again, this is just kind of review from lab. Okay, so these are the major hormones that come out of the anterior pituitary gland. So let's start with ACTH. There's a really nice picture of this in your book as well. I would recommend that you reference this, take notes. Okay. ACTH is adrenal corticotrophic hormone. ACTH is adrenal corticotrophic hormone. So where do you suppose that hormone's going to work? The adrenal cortex, right? And it causes the cortex to release cortisol, right? Corticosteroids. Okay, and these are your mineral and your glucocorticoids. You guys cool with that? Okay, cool. So that's ACTH. Okay. The next hormone that comes from the anterior is TSH. That's thyroid stimulating hormone, right? That stimulates the thyroid to secrete thyroxine, okay, and it's hormone. So T3 and then T4 is thyroxine, right? And these are hormones that regulate general metabolism, right? So increased T3 and T4 increases general body metabolism, decreases. You guys okay with that? The next hormone is GH, or growth hormone. And this tends to target your bones and muscles and causes them to grow. All right. The next one is prolactin, or PRL, that primarily acts on tissue within the breast, within the female breast, when it comes to lactation. And then you have LH and FSH, that's luteinizing hormone is LH. FSH is follicle stimulating hormone. And these hormones stimulate another endocrine organ known as the gonads, right? And in women that tends to be ovaries, right? And in men that tends to be the testes. And you have progesterone, estrogen, testosterone are the three major sex hormones that come out of the gonads. And then finally, I put this in for the sake of completion, and because it's in the book as well, but there's this hormone called MSH that's melanocyte stimulating hormone. And what exactly is going on there? What exactly is going on there? Question mark. To be determined. We're not quite sure exactly. But anyway, I threw that in for completion's sake. Okay, you guys okay with that? Now, some other endocrine organs you need to be aware of. The pineal gland, where is that located? The pineal gland, where is that located? In the brain. It's located in the brain. It releases a hormone called melatonin, right? Melatonin is very important in our sleep-wake cycle, right? In our circadian rhythm. Okay, there is a system, okay? I don't think I mentioned it here under consciousness, but I'll mention it here now. There is a system known, in the brainstem, it originates from the brainstem. It's known as the RAS, or the reticular activating system. And the reticular activating system, here it is in the notes here, okay, is what awakens us, allows us to become conscious, okay? And melatonin and many other things, of course, are involved in that. But melatonin is really important. Higher increased levels of melatonin kind of coincide with the sun going down and us kind of getting sleepy and going into our night cycle. Decreased levels are associated with waking up. All right. The kidneys themselves release two important hormones. Okay, so not only are the kidneys acted upon by hormones, but they release hormones. They release something called EPO, or erythropoietin. Erythropoietin is a hormone that stimulates the production of red blood cells. So people that have kidney damage or kidney failure, we call renal failure, sometimes they may develop something known as anemia, that is a lack of red blood cells. They become anemic because their kidneys are not secreting erythropoietin. Does that kind of make sense? All right. So oftentimes we will have to inject them every so often with erythropoietin to kind of get their body to make more red blood cells. The other hormone that comes from the kidneys that's important is something known as renin. And I'm going to talk about renin because there's a whole system known as the renin-angiotensin-aldosterone system. And I'm going to talk about that in some detail. Okay? Our old friend the pancreas, right? It also has an endocrine function, specifically in the islets, right? The islets of Langerhans. Okay? And you have alpha, beta, and delta cells. The alpha cells secrete glucagon. When we talked about glucagon, that causes glycogen to break down into glucose, right? So if our blood sugar gets low, glucagon is released, and then that causes glycogen to break down into glucose and increase our blood sugar. Okay, the beta cells secrete insulin, and insulin is a very important facilitating molecule, right? It facilitates the movement, okay? It facilitates diffusion of glucose into the cell, where glucose then can be turned into ATP through glycolysis, the Krebs cycle, and oxidative phosphorylation. And then the delta cells secrete something called somatostatin. And somatostatin is an important inhibitory hormone. It inhibits the release of glucagon and insulin. And it also does some inhibition of growth hormone as well. Okay. Your adrenal medulla. Okay. The adrenal medulla is important because it releases epinephrine and norepinephrine. Those are important sympathetic hormones. We talked about that in the autonomic nervous system last week. And then the lungs themselves secrete an enzyme known as angiotensin converting enzyme, or ACE. And that is important here in the renin-angiotensin-aldosterone system. Okay? So these are the major players. Okay, the stage is set. One other player that I did not talk about, and I guess I'll mention it now, are the parathyroid glands. Where are they located? Yeah. You generally have 4 of them. Okay, they release parathyroid hormone and parathormone. And what are they? Do they tend to regulate? It's an ion that they tend to regulate, those hormones. They tend to regulate calcium levels. So calcium ion levels are very important. All right, you guys okay there? All right. So let's now talk about the renin-angiotensin-aldosterone system. Okay. This is an important system when it comes to the kidneys. Okay. And so here's how it works. Your kidneys tend to need a lot of blood flow, right? A lot of blood flow goes through the kidneys, and you're going to talk about the kidneys in a lot of detail next semester. But there's a concept known as the GFR, the glomerular filtration rate. And the glomerulus is a part of the functional structure of the kidneys known as the nephron. And basically it's where blood comes in. Okay? Blood comes in into the glomerulus. And when the filtration rate is very low, that means there's not a lot of blood or not a lot of perfusion getting into the kidneys. And when they detect that, the kidneys go, oh, we're not getting perfused. We need more perfusion. The blood pressure is low. We may be dehydrated. Things aren't going well here. So they release a hormone called renin. So GFR goes down, renin is released. Okay. Now, floating around in your blood, you have a prohormone known as angiotensinogen. Okay? Just like in the lab when I talked about pepsinogen, right? And it's an inactive hormone until stomach acid, right? Until a low pH, high acid levels, turns it into pepsin, right? Same thing here. Angiotensinogen is inactivated until renin comes into contact with it. So the kidney releases the renin converts the angiotensinogen into angiotensin 1. Now, angiotensin 1 is still inactive. And so what happens is that angiotensin 1 eventually gets circulated through the lungs here, and there's an enzyme known as angiotensin converting enzyme in the lungs, and that converts angiotensin 1 into angiotensin 2. Angiotensin 2 is the active form of angiotensinogen. Oh, you guys okay with that? So renin activates angiotensinogen to angiotensin 1, and then ACE turns angiotensin 1 into angiotensin 2. You guys okay there? Angiotensin 2 does two things. The first thing that it does is it acts upon your blood vessels. And so here you have a dilated vessel and a constricted vessel. It causes vasoconstriction. So the vessels constrict, and what does that do to our blood pressure?
Increase.
Right? Okay, increases blood pressure, blood kind of gets pushed toward the kidneys. The other thing that it does is it comes over here and it activates the adrenal gland. Okay, angiotensin 2 tells the adrenal gland to release another hormone known as aldosterone. Aldosterone is a type of mineral corticoid. And what it does is it tells the kidney to tells the body to hold on to water. So you are vasoconstricting, you're holding on to water, and hopefully those two things together will increase the glomerular filtration rate, increase perfusion into the kidneys. Does that make sense? And once the perfusion increases, the renin release stops. And of course, this is an example of what kind of feedback.
Negative.
This is a classic example of a negative feedback loop. Absolutely. Right? Fixing the problem inhibits. Yes, sir.
Is this where the aldosterone makes the kidneys saltier, essentially?
Yeah, well, basically aldosterone, kind of helps you hold on to salt. And as the saying goes, where salt goes, water follows, right? So you keep salt in there, and that keeps water in there. If you get rid of lots of salt, the water tends to follow the salt out. Yeah. You guys good with that? So far, so good? Okay. Now what I want to do to finish up is I want to talk about some disorders. There are lots of endocrine disorders. Lots of problems can go wrong here. Okay? So what I'm going to do is I'm going to talk about 3 sets of disorders. Think of these as sets. Okay? The first set involves antidiuretic hormone, ADH. The other name for ADH, okay? ADH is also known as vasopressin. All right. Also known as vasopressin. Okay. So you have 2 disorders of vasopressin or ADH. you have something known as SIADH, that is Syndrome of Inappropriate Antidiuretic Hormone. Okay? In SIADH, we have too much ADH. Too much ADH is being released by the posterior pituitary gland. What that does is that causes the kidneys to hold on to water. And so you are not getting rid of water, which means water is building up in your body and you are becoming overhydrated potentially. Does that make sense? You're not peeing, you're not getting rid of excess water, you become overhydrated. And eventually what that can do is that can dilute the sodium in your blood out. That's known as dilutional hyponatremia. Hyponatremia means low blood sodium. And when you dilute the blood out, the blood becomes hypotonic. You guys remember the beginning of the semester talking about tonicity? The blood becomes hypotonic, which causes water to shift into the cells. Cells begin to swell, particularly cells in your brain begin to swell. Okay, this can cause cerebral edema or swelling of the brain. Now contrast that with another disorder known as DI, or diabetes insipidus. This is not the typical kind of diabetes that you may be used to. This is a very different kind. In diabetes insipidus, you have very low levels of ADH. So that means that your kidneys cannot hold on to water, and so what do? You pee, and you pee, and you pee, and you pee, and then you get really thirsty, and you drink, and you drink, and you drink, and you pee, and you pee, and you pee, and it's this vicious cycle that is formed. Does that make sense? That's diabetes insipidus. So SIADH, too much ADH. Diabetes insipidus, too little ADH. You guys okay there? The next set of disorders are disorders involving cortisol. Okay, so this is the adrenal cortex here. All right. The first one is Cushing's syndrome. This is a syndrome where there is too much cortisol. Okay? And so what happens with these people is they have too much cortisol, so their blood sugar tends to be high. They tend to have problems with lipids. They end up developing fat deposits in an area where you don't normally have fat. And they can get what's called a buffalo hump, where they get fat developed behind their neck. They tend to develop male pattern hair. So if this is a woman that has Cushing's, they tend to get hair in places where you don't normally see hair in women. They tend to get a really fatty, what we call moon face. Their face gets really round and fatty. And they get what are known as striae. And striae are basically, you guys have all seen stretch marks, right? These are stretch marks on steroids. Well, literally, because you have too many steroids there. And they become large, purple, nasty-looking stretch marks that tend to develop. Okay, that's all Cushing's syndrome. Now, the other syndrome, okay, is something known as Addison's disease. And Addison's disease is too little cortisol, not enough cortisol, okay? And this can actually be life-threatening. And when it's life-threatening, it's something known as Addison's crisis, okay? Because these people can't regulate their water, they can't regulate their sugar, what happens? They can get dehydrated, their electrolytes can get out of balance, their sugar can get low, their blood pressure can get really low, and they can have this intense, incredible abdominal pain that develops. So they get this incredible abdominal pain, their blood pressure crashes, they get really, really sick. Okay, you guys okay there? Again, Cushing's syndrome, too much cortisol. Addison's disease, too little, not enough cortisol. And then finally, the third set of disorders I want you guys to be aware of are disorders that involve T3 and T4, okay, thyroid hormones. There's this disorder where we have too much thyroid hormone. That's known as hyperthyroidism. And what is someone with hyperthyroidism going to look like? Well, their metabolism is going to be too high, right? So their heart rate's going to be fast, their blood pressure to be elevated, they're going to lose weight, their temperature's going to be elevated, they're not going to tolerate the heat very well. And this can actually be life-threatening. And when it's life-threatening, it's something known as thyrotoxicosis. Okay, where they get severe elevations of blood pressure, severe heart rate elevations, or what we call tachycardia. The other name for hyperthyroidism is Graves' disease. Okay, Graves' disease is another name for hyperthyroidism. You guys okay with that? So far, so good? Okay. Contrast that with hypothyroidism. What is hypothyroidism? Too little thyroxine, too little T3, T4. So what's going to happen? Well, opposite of hyperthyroidism, right? They're going to have weight gain. They're not going to tolerate the cold very much. They're going to have a decreased heart rate. They're decreased temperature. They may be a little lethargic as well. Okay, does that all kind of make sense? What would happen there? All right. And then finally, last but not least, I want to talk about the most common endocrine disorder that we run into, and that is something known as diabetes mellitus. Okay, so it's not diabetes insipidus, where I insipidusly lose water, but it's mellitus. It means wasting away. It literally means wasting away disease. Okay, so diabetes is fundamentally a problem with sugar, right? It is an inability to regulate our blood sugar. Okay. Now there are two flavors of diabetes, and they couldn't be more different. Okay, the first flavor is what we call type 1 diabetes. Okay. This is sometimes also known as IDDM, or insulin-dependent diabetes mellitus. Okay? IDDM, or type 1. Type 1 is the proper medical terminology. What happens in type 1 diabetes is these patients, or these people, have a loss of their beta cells. They lose their beta cells, which means they lose all ability to make insulin. They cannot make insulin, period. That's it. No insulin. Okay? What leads to this is an area of active research, but there seems to be a very strong autoimmune component. And we often see this in kids. This is also sometimes known as juvenile onset. And what we see in kids is that a kid will get sick. They'll have like a cold or the flu or Epstein-Barr virus, and then when they recover from the virus, they end up developing diabetes. And we think what may happen is the body's immune system gets activated and it fights a virus, and it kind of takes out their beta cells as collateral damage, if you will. Okay, so they don't make any insulin at all, and this leads to a very particular problem, something known as DKA. DKA stands for diabetic ketoacidosis. You guys okay with that? And what happens in DKA, because they don't make insulin, they can't use sugar for energy, right? So what do they have to resort to make energy? They have to break fat down. They break fats down. They break fats down into acetyl-CoA, and then you can feed the acetyl-CoA into the Krebs cycle and make energy. The problem with breaking down lots of fat is it's kind of inefficient, and you make a lot of what are called ketone bodies, things like acetone, okay? And you make lots of acids. Does that make sense? So the waste products, okay, of breaking down the fats, the waste products are these ketone bodies in these acids, and so your patients get very acidotic. Okay? But what's happening to their sugar? Is the sugar going into the cells? No, because they're not making any insulin, right? So the sugar level just continues to rise, right? Because it doesn't have anywhere to go. And then eventually it gets so high that the kidneys, it starts spilling out in your urine. And then once that happens, it starts pulling water out of your body. Right? Water starts leaving your body to get rid of the sugar. So then you start peeing. You pee, right? And you get very dehydrated. So somebody in DKA, their sugars are really high. They're really dehydrated. They have lots of ketone bodies, and they're very acidotic. So overall, that makes for a very sick person. Does that make sense? Very sick person. Now, the other type of diabetes is something known as type 2, or some people sometimes call this NIDDM, non-insulin dependent diabetes mellitus, or adult onset, because this tends to occur in adult patients. In type 2 diabetics, it's not the loss of beta cells that's a problem. Type 2 diabetics can make insulin. The problem is that the cells of their body become insulin resistant. That is, the cells in their body become used to high levels of insulin, and the pancreas cannot make enough insulin to activate those resistant cells, right? Does that make sense? Those cells are resistant to insulin. Okay. So this is very different than type 1, and in this there are many options for treatment. In a lot of cases, if you can get somebody on a diet, and you can get them to lose weight, and you can get them to eat and be active, in a lot of cases, you can actually reverse that diabetes, and they'll get better, right? And they may not need medications, or as much medications. Okay. Now, if their insulin resistance gets to the point where it's really, really bad and their sugars are really high, we may have to put them on medicines. And most of the medicines, the oral medicines that we give them, what those medicines do is they stimulate the pancreas to release more insulin. Okay? And then if those fail and the dieting and exercising fails, we may actually have to get them on insulin as well to give them additional injections of insulin to increase the insulin levels in their body to get through to those resistant cells. Okay, you guys okay with that? So these people tend not to go into DKA because they make insulin, right? So sugar can get in, some sugar can get into the cells. So we do not see DKA in type 2 diabetics like we see in type 1. And then this takes us basically to the end of the chapter, where it talks about long-term consequences or long-term sequelae of diabetes. Chronically elevated sugar in your blood is pretty toxic to the body. Okay, so people with diabetes are at high risk for damage to their kidneys, renal failure. Diabetes is a leading cause of renal failure. Okay. We have a lot of it down here, a lot of people on dialysis. A lot of them are diabetics. Of course, high blood pressure, hypertension is another leading cause. Retinopathy, or disease of the retinas, very common problem with chronically elevated blood sugars. Peripheral neuropathy, or damage to peripheral nerves, okay? And so these people lose sensation, or they can get pins and needles feelings, and they are prone to developing breakdown of their skin and ulcers and infections. Okay, they're immunocompromised. And so that can also lead to cardiovascular risks. Okay, so heart attack and stroke risk is going to be a lot higher in diabetic patients, particularly diabetics who do not have a well-controlled blood sugar. You guys okay there? And then finally, the very last thing that this chapter talks about is something known as the general adaptation, or the stress response. And I just want to briefly talk about the stress response. All right, the general adaptation syndrome. It basically is broken into 3 components. The first component is what's known, I believe, as the alarm. They call it the alarm stage. Is that what the textbook calls it as well? Okay. And so this is the initial moment when you place somebody in an acutely stressful situation, okay? So let's say that I'm in Syria and a bombing occurs, right? There's a bombing that occurs. Or let's say like when I was in Afghanistan, for example, I was working in Afghanistan and there were some bombings that occurred. That put me in an acutely stressed out situation. What if you had to imagine what kinds of hormones are going to be involved in this acute response? Epinephrine and norepinephrine, right? So this is primarily a sympathetic response. Epinephrine, norepinephrine. And so now let's say it's been a few days or a few weeks, and I'm getting bombings every week, and there's shootings happening all the time, and that stress doesn't go away. I'm continuing with that stress. Then what starts to happen? Well, my body needs to start mobilizing. It needs to make energy, and it needs to kind of have to deal with this longer term stress. And so what kinds of hormones then become more important? Oh, look, there's a second picture there. So the first one is a sympathetic, all that, right? The second one, what kinds of hormones are important there?
Glucose.
Yeah, your
Metabolic.
adrenal hormones, right? Your mineral and your glucocorticoids. You say that there?
Yes.
Yeah, right? Because we need to continue to get our blood sugar up. We're trying to regulate water balance, okay? And so now you have cortisol. Okay, cortisol becomes important in the second stage, and that is known as resistance. Okay, you begin to resist that, all right? And then eventually what happens is all of your ability, all of the mechanisms break down, and then you go into what's known as the exhaustion stage. Okay, and in the exhaustion stage, right, you are going to be at risk for infections. You're going to be at risk for lots of psychological issues and fluid and electrolyte imbalance problems and just general body breakdown, generally your body not working. Okay, good. So that's all I wanted to mention there. You guys okay with that? Okay, let's now